So we did publish a trial, and I should point out that Bruce Ritter did most of the work, so he was the first author, and David Harris, whom you may also know from the ISN, and myself were the PIs in the study. But it was oversighted by a steering committee, and who I should acknowledge they all put in a lot of work. Now, I need to emphasise it's not an early referral study. All these patients have been seen by a nephrologist for 30 months or so. So these are people who were very much under nephrology care at the time of the start of dialysis. And as per our population in Australia, the majority of the people that we enrolled were Caucasian. Oh, I should also point out the average age was about 60. And we had about males were twice as more likely to be enrolled in the trial as what females were. Now, the creatinine enrollment in the early start group and the late start group are very similar. A creatinine of 530 micromoles per litre is about 6.2 milligrams per deciliter. And we use the Cockcroft-Walt formula because at the time we were conceiving this study, the Cockcroft-Walt was much more in common usage than was the MDRD. And you'll see immediately that there's a discrepancy between the two calculations. At the time of randomisation, the Cockcroft-Walt formula was 13 in both groups, but it was estimated to be just under 10 by the MDRD study. They were well nourished and they had a reasonable hemoglobin equal in both groups. Now, the time of dialysis patient that we see is very similar to the Indian population. More and more we see more diabetic nephropathy in people who are starting dialysis. I guess we don't see quite as many undetermined, and we see more renovascular disease than what we do. But in general, the populations aren't too dissimilar. Where there is some dissimilarity is the mean age of this is a group from the northern part of India, where their diabetes was very similar, but the age is somewhat less than what our dialysis study was. Our mean age of 60, this is 44. The majority were emergency presentations, and the majority of patients were lost, or a significant number of patients were lost to follow-up, whereas in our population, we get 99.9% of people we had very good follow-up data on throughout ANZ data registry. And very few people continue on maintenance hemodialysis. So it would be very difficult for the Indian dialysis community to have done a study like this. So when we looked at the timing of the start of dialysis, the study was designed to start dialysis in the early group between 10 and 15, and then later group less than 7. And you'll see we didn't achieve that, but we did achieve a statistical significance at around 2.2 mils per minute. Many people in the late start group started dialysis early, and the majority of the reason why they started dialysis early was because of symptomatic renal failure, as judged by the physician. People in the early start group less commonly started dialysis late, and the main reason, even though they were in the trial, was a delay in access creation. And very few people started dialysis late in the early start group because of the patient or physician direction. So even in this trial, there was a move to the physician suggesting that the patient should be starting dialysis early. Having said that, there was a delay of at least 6 months in the timing of the groups between those who started dialysis early versus those who started dialysis late. And in the late start group, you'll see a significant number of people actually could delay their dialysis for if not 1 year, for up to 2 years. So there was definitely a benefit in those patients to be able to get into the late start group. Now, if we look at that timing of about 6 months in terms of the deferral of dialysis, that really looks back to about where we were in 1997. You'll see this graph here looks at the mean number of days that dialysis was started earlier in 2007 versus in 1997. So here's about 180 days, and you can see the majority of people who started dialysis early was by far and away the elderly population, those here who were greater than 75, and in fact the younger population hadn't so much started dialysis early. Interestingly, the presence of diabetes or vascular disease, of heart failure and significant comorbidity didn't necessarily make people start dialysis earlier or later. Everybody was starting dialysis earlier. And as you know, our study demonstrated that it didn't matter whether you electively started dialysis earlier, it made no difference to your outcome. You were just as likely to die or survive if you started dialysis early or started dialysis late. Now, when we look at the outcomes, there was no difference in any of the primary outcomes, the primary outcome being survival. So survival was very similar. Cardiac outcomes were very similar, not statistically different, and if anything, the event rate was higher in the groups who started dialysis early versus the group who started dialysis late. But there's no statistical significance in any of these cardiac outcomes, no differences in infection or hospitalisation rate. Similarly, there was no difference in the complications of dialysis, whether you started dialysis early or late. One of the views is if you started dialysis early, you were going to get more dialysis-related complications. That didn't occur. We didn't have more deaths from cancer, which is something that we always need to pre-specify in these large studies. So if we look at the challenges in the infant population, the survival is fairly poor. The median survival is 410 days, and the reason for the poor survival is not just death, there's also a significant loss of follow-up, so death is sensitive in that group. There's also a significant number of people who get transferred, and there's very few transplants, and only 16% of patients continue dialysis in the longer term. Having said that, the people that do die, the causes are very similar to in our population, in that most people die of either ischemic heart disease, sudden death, or a vascular cause of death, with infection being the commonest cause. The risk factors for mortality are also similar, being an older age, being female gender, and smoking, and being poorly nourished, as well as having background ischemic heart disease. Interestingly, emergency dialysis in this Indian population gave a better outcome, but I think that that's because probably acute kidney injury was included in this population, and therefore people with acute kidney injury were dialyzed a lot better, as opposed to people who had chronic renal failure presenting late. In our study, we looked at whether or not there may be a subgroup who may benefit from early dialysis, or alternatively from later dialysis, and there really wasn't any group that we could identify that should be started on dialysis earlier. So if you look at the older population, no matter how old you were, you didn't benefit from early start dialysis. If you had diabetes, you didn't demonstrate any benefit. Obesity made no difference, neither did the presence of cardiovascular disease or hypoalbuminemia, so there was no benefit in starting dialysis because of poor nutrition. You should just fix the poor nutrition. So despite this, we know that people with diabetes were starting dialysis earlier than the general population, again with the view that maybe because of the comorbidity of diabetes and renal failure are very similar, so maybe we should dialyse people and then that takes away that comorbidity, and it wasn't proven in our study. So the key findings in the ideal study was that planned early initiation of dialysis in people with stage 5 chronic kidney disease wasn't associated with improved outcomes or improved mortality. And the sub-analysis demonstrated consistency. Now, while we were doing our study, and just as we were publishing it, there was actually other data that was coming out and emerging from registries in particular, suggesting that if you started dialysis late, you might actually do better. And this is the USRDS study of over 10 years, up to 2008, where it demonstrated that people who started dialysis later, with an estimated GFR at the MDRD, using the MDRD formula between 0 and 5, did much better than people who started dialysis with an eGFR of greater than 15, with a graded benefit in re-analysis of our data to see if we could demonstrate the same benefit of starting dialysis late. If we use the Cockcroft-Walt formula, you'll see that you can get any and divide the patients into tertiles at the actual time they started dialysis. We didn't actually get any benefit if we started dialysis late. This is the lowest tertile versus early in the highest tertile. Very much overlapping. However, if we use the MDID formula, then we again found that if you started dialysis later, you had a better outcome than if you started dialysis earlier, with these two groups very much overlapping. Now, if we then did the estimated GFR by the CKD equation, we again found the same thing, starting dialysis later. If you could manage to start dialysis later and there was no other indication to start dialysis, meant that we did better overall. Now, we then looked at whether or not there was a gender effect, and there certainly was a gender effect. It was much worse if you were a female to start dialysis early. So this is the females here, who started dialysis early, and you can see they did much worse than if you were able to start dialysis later. And the benefit in terms of starting dialysis later was largely seen in the male population. So don't start females on dialysis early if they don't need to start dialysis just because of their estimated GFR. They'll do worse, and males, if they get deferred dialysis, will do much better. So then why do we get these different results? And the reason we get these different results, depending on which equation we use, is that the validation of estimated GFR at low levels of kidney function is very poor. So if you look at the Cockcroft-Walt formula, and it's still recommended that we drug dose using the Cockcroft-Walt formula, at least in Australia, there was only 249 patients that were used to develop that equation. And the lowest GFR was in the oldest population, which isn't surprising, but the mean GFR was 37. So there were very few people whose GFR was low. In the MDID study, there were large numbers, but by no means large numbers. And the mean GFR was again 39.8. Remember, that was the study where your GFR was between 20 and 55. So they had very low levels of people, low numbers who had low GFRs, and very few numbers who had GFRs above about an estimated level of about 60. And in the CKD, which is a larger study, a population-based study, again, there are only 2.6% of patients in the validation sample. So it's not surprising that the confidence limits are very wide when you get down to very low levels of GFR. So it's been questioned as to why we bother measuring estimated GFR in stage 5 chronic kidney disease. Why would we do it? What is it going to change? It might change drug dosing, so that would be a reason to do it. It shouldn't influence your decision making about when to start dialysis. The presence of uremia shouldn't influence your decision about that. And I think at the moment there's very little reason to actually measure the estimated GFR in stage 5 chronic kidney disease. You if we look at age, this again is USRDS data, and it's from about 320 patients who are less than 65 without any comorbidity. So it's a well population. If you look at this in an observational sense, these people do much worse if they start dialysis early. So there are better patients, if you like. Starting them early is doing them a disservice. Their hazard ratio of death is more than twofold if you start with GFR of more than 15% of kidney function. So don't do that. So what about in people who are elderly? Now we know dialysis can keep most people alive. So this just demonstrates that the older population with stage 5 chronic kidney disease, if you dialyse people, they're more likely to survive than if you treat them with conservative therapy. However, if you have more than 3 comorbidities, your likelihood of dying on dialysis is the same as if you get optimal conservative therapy. So I'm always showing my older patients this sort of data, because if they think that dialysis is going to save them, then it's not correct. And I think some people, I'm sure you've all got patients who think you have to do everything, otherwise you're not doing the best for your family members in particular, but there's no data to support that. Ischemic heart disease is a major comorbidity that affects mortality, and if you don't have ischemic heart disease, then your outcome on dialysis is better. So there's no surprises there. Now, the same data comes out of your population. Obviously, the people who are younger tend to do better on dialysis than the people who are older. And I think this data was, the discussion around this data was that people over 65 still have a 40% survival at 2 years, but it's, I wouldn't suggest that that's a great survival. So I think that there's probably more that can be done, particularly in the older population. But I do think we need to have an age-specific approach to dialysis, and I completely concur with the prior speaker who suggested that one size doesn't fit all, and it's exactly the same when you make a decision about who should start dialysis. One size absolutely doesn't fit all. So I think we need to look at the comorbidity and ask ourselves the surprise question, would I be surprised if this person died within the next 12 months? If the answer is yes, they probably will. Advanced care directives is something we need to discuss early in the course of chronic kidney disease. Do they want dialysis? What would be the point where they would want to stop dialysis? And I think we also need to look at the issue of the functional trajectory of the decline in kidney function, because that also is important. If you decline in your kidney function very slowly, this is less than about 3 mL per minute per year, you have much better survival than if you have a rapid decline in kidney function, because that's more likely to be due to comorbidity. And this data here that was from just last year demonstrated that in the 12 months prior to starting dialysis, your eGFR was higher compared to lower, even though your dialysis start was not terribly much different here, based on the fact that the confidence limits are quite wide. This is the group here that do very badly, the people who start off not too badly and decline very quickly. What about the issue of early referral? This is DOPS data that demonstrated that if you were referred early, you had better survival than if you were referred late, and if you had more nephrology visits, you did better. So it made all of us nephrologists feel good. So what we did was we compared our late start in patients who were in the IDEAL study, and we then went to ANS data, which is our registry of all our dialysis patients, and looked at those who had been referred early, more than 3 months prior to the start of dialysis, versus late, less than 3 months prior to the start of dialysis. We tried to match the populations, but they were difficult to match. You can see there's not that much difference within the confidence limits of the estimate in the starting GFR, and there's not that much difference between the age, but there were some differences in the race. If you started dialysis